All right, this is venous disorders. So venous disorders are, of course, problems with the veins that cause interference in having an adequate return of blood flow from the extremities. So this is a problem with the return. There's three types. There's VTE, which is venous thromboembolism, venous insufficiency, and varicose veins. With VTE, Virchow's triad occurs, and this is when you have venostasis, endothelial injury, or hypercoagulability, and it causes a blood clot. The etiology or risk factors for DVT, if you remember the acronym thrombosis, so trauma, hormones like birth control pills, road traffic accidents, operations, like orthopedic operations, malignancy like cancer, certain blood disorders like polycythemia, that's like a hypercoagulable blood disorder, being obese or being old can cause DVT. Having a serious illness like being septic, being immobilized like being in a hospital bed, or splenectomy. The clinical picture, what it looks like, you have leg swelling. Sometimes the leg can be like twice the size of the other leg, but I haven't really noticed too much leg swelling when I've seen a DVT, but you can have it. Have leg pain that increases with walking or standing. So please don't get that leg pain that increases with walking or standing confused with the intermittent claudication of PAD, because intermittent claudication, you do have pain that occurs with walking or standing, but it's not like all the time. It just happens. It's all of a sudden. This is an increase with walking or standing. With DVT, you might see visible surface veins. Then you're going to have warmth and redness of the affected leg skin and fatigue of the affected leg. The lab test to kind of make you think, hey, they might have a blood clot, is called a D-dimer. The D-dimer is a blood test, so it's not as invasive, which is why they do it first before they do other tests. But if the D-dimer, it basically looks at the fibrin, and so if it's elevated, you're at an increased risk of having a blood clot. So if the D-dimer is elevated, then they will do the other tests to see if you have a blood clot. Like for a pulmonary embolus, it would be a CTA, which is a angiography CAT scan, and you need an 18 or a 20 for that. And then for the DVT, it would be an ultrasound of the leg. So they might just order the ultrasound of the leg and not even bother with the D-dimer, but I think the D-dimer is cheaper, which is why they do that first. Nursing care. So this is to help prevent DVT, not treat DVT. So prevention, we have our SEDs. Those like squeeze our legs when we're in the hospital. Movement, get up and walk. Movement is much better than sitting still because movement helps prevent DVT, whereas sitting still can cause issues. In the hospital, they are probably going to be on anticoagulant therapy like low-dose heparin. And then they also might put them on TED hoses. When they have a DVT, so this is when they have a DVT, they may want to put them on bed rest. It's kind of up in the air about that. Sometimes they want to do early ambulation. They do not want the limb to be massaged, because when you massage the limb, you break the DVT. You could break the DVT off, and it could go to the lungs and cause a pulmonary embolus. Give warm, moist compresses. That might help with the pain. Thigh-length compression stockings or TED hoses. And do not put SEDs on an active DVT leg. And then prepare for possible surgery. So prophylaxis, mechanical, SEDs, TED hoses, ambulation, active movement. Then pharmacological is an anticoagulant of some form. So with venous thromboembolism, if they have a VTE, you're going to give them IV heparin, unfractionated heparin. The heparin will prevent further clot development, but it does not break up a clot. It does have significant adverse effects, one of them being being HIT, which is heparin-induced thrombocytopenia, which I will talk more about in the next slide. So the nursing action is to monitor your APTT for dosing, and your hospital will have a protocol for that. The therapeutic range is 1.5 to 2.5 times the baseline, and the baseline of a PTT is 21 to 35 seconds. At ANMED, the pharmacy doses that, and I don't have to worry about that, like dosing it. It just, they tell me where to titrate, and that's what I do. But some hospitals, you might not be so it might not be so, easy for you. You might have to do it yourself. So what you will have a protocol that hospital follows. Please do not spend a bunch of time on figuring out how to do this. This is like going to be one question. There is going to be an IV heparin math question. So if you really need help figuring it out, come talk to me. But I will give you everything as far as what the PTT is, what you're supposed to titrate it to. Like, you just have to figure the math part out. Remember that heparin has a half-life of 60 minutes, and there is an antidote available for heparin, and it's called protamine sulfate. You want to monitor your platelets for heparin-induced thrombocytopenia when they are on IV heparin. And then you're also going to monitor for other adverse effects. Heparin-induced thrombocytopenia, or HIT, is a very interesting thrombocytopenia because you have low platelets, but you don't generally bleed. You're hypercoagulable, which is interesting, I think. So you're going to have like this red, rough, sloughy looking skin with HIT. Like, this is pretty significant. It might not be that significant, but the important thing to remember is that you need to discontinue what's causing it. So the heparin, they're hypercoagulable even though their platelets are low, so they need to be put on an alternate anticoagulant therapy. So when you have an active VTE, they might want to do some kind of thrombolytic therapy. And thrombolytic therapy means that the clot will be dissolved. So thrombo for thrombus, lytic for break up. It needs to be started within 5 days of clot development. And what they do is they administer medicine directly to the clot. That's like most effective. I have never given thrombolytics like streptokinase. Like, I've never given that. Most of the time they go to cath lab or endovascular where they have thrombolytics placed directly onto the clot. The main thing you need to be aware of is monitor for bleeding and educate on bleeding precautions. So with prophylaxis of VTE, we're going to put the patient on low molecular weight heparin, or heparin. This is given sub-Q, and it's weight-based. Enoxaparin or heparin are your big two examples. You want to observe for bleeding. You want to teach the patient to observe for bleeding, teach the patient to look for significant bruising in their belly. They need to know to rotate their injection sites. So if you have a patient that's alert and oriented, you ask them, hey, where'd you get this last time? And they say the left, you give it on the right. Why are you rotating injection sites? Because, well, the medicine hurts and it needs to be rotated. Soft bristle toothbrush, electric razor. Make sure before you give any type of medicine sub-Q that you look at their platelet counts. If their platelets are below 100, you do not give the medicine. The normal platelet is 150 to 450, but you can go as low as 100 and give this prophylaxis medicine. But if it's below 100, do not give it. And if this is applicable, you're going to check the PT, PTT, and INR. Now, PT and INR are going to be warfarin. PTT is going to be heparin. So warfarin inhibits the synthesis of clotting factors. And these are vitamin K dependent clotting factors, which is why the antidote is vitamin K. Please, please, please do not get vitamin K and potassium mixed up. Vitamin K in our diet, green leafy vegetables. Potassium, citrus fruits. The therapeutic effect of warfarin is 3 to 4 days. So if somebody has been on IV heparin for a clot, they are going to keep them on heparin and put them on warfarin and leave them on heparin for a few days until that INR is therapeutic between 2 and 3. Now, the normal PT is 11 to 13 seconds, and the therapeutic PT is 1.5 to 2.5 of that. But really what they mostly concern themselves with is the INR. Because it took me forever to find the therapeutic PT, and I'm not going to have you guys be like, what? So INR, make sure that INR is therapeutic if they are on warfarin, and it's 2 to 3 to be therapeutic. You want to ensure that the antidote is available. The antidote is vitamin K. Teach your patient to avoid sources of vitamin K. Now, if your patient was eating vitamin K beforehand, like they loved their collards and they were eating a bunch of collards, they can still eat a bunch of collards. They just don't need to increase their collard intake. You want to give them education about bleeding and tell them what kind of precautions they need to take. All right, surgical management. So if somebody has a DVT, they are going to put in a Greenfield filter so that the DVT does not travel and become a PE. They do this when you can't give them anticoagulant or thrombolytic therapy. So when somebody has a PE, the filter, it traps large emboli and it helps prevent the PE. And that's just a picture of what it looks like. Venous insufficiency. So venous insufficiency, it occurs because of valves in the extremities, in the deeper veins of the lower extremities, and it allows pulling of the blood and dilation of the veins. So the vein is unable to carry fluid and waste from the lower extremities, and this causes swelling, venous stasis ulcers, and in significantly advanced cases, some cellulitis, which is why cellulitis is in this chapter. So venous insufficiency risk factors. So risk factors: sitting or standing in one place for long periods, being overweight or obese, being pregnant because you're big, and then thrombophlebitis is a risk factor. It's a thrombus that's associated with inflammation. So this is just a picture of what venous insufficiency looks like and what varicose veins look like. So venous insufficiency, you'll have leg swelling, skin color and texture changes, and venous ulcers. But with varicose veins, it's basically you're going to have bulging veins. So nursing care with venous insufficiency, you want to elevate the legs 4 to 5 times a day. Elevate above the heart. Avoid crossing and remove constrictive clothing, and educate to wear compression stockings. Interprofessional care of venous stasis ulcers requires long-term management. So like if they're going to go home, they need a bunch of education about wound care. A wound care consult if they should have a venous stasis ulcer or an arterial ulcer, because wound care knows a lot more than what you are going to know. They know more than what I know. I love wound care. And maybe a consult to a dietitian to help them understand what they should eat to help out healing, like increase their protein maybe. And then varicose veins. These are enlarged, twisted, torturous looking veins that are superficial and bulging. Varicose vein risk factors, well, of course, if you're a woman, over 30, if you work for long periods of time with standing in one place, if you are pregnant or overweight, and then kind of also like having systemic disease processes that can cause you to have varicose veins or a family history of varicose veins. So this is just a picture of what happens with the varicose vein. You see that the valve isn't closing correctly, so you're not having adequate blood flow. Your expected findings with varicose veins is that they will have limb pain that's aching, and it has a feeling of fullness or heaviness in your legs after standing. This is a picture of veins dripping, because that is one way to treat it. They basically just strip out the part that is varicosed. And then another type of treatment is sclerotherapy, where they inject some kind of medicine to help kind of smooth out the vein. This is a picture of what happens with lymphedema. It actually looks more like thrombophlebitis. This is lymphedema. So with lymphedema, you have your lymph nodes or your lymphatic system is incapable of filtering your fluids. So you get edematous in your arms or legs. So never, ever, 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 ever take blood pressure on the side where the lymph nodes have been removed. Some ways to help with lymphedema is elevation, of course, and compression. And then with cellulitis, it's basically an infection of the skin that gets into the blood. So the way cellulitis can occur is a break in your skin, which, as you know, is your largest barrier. And this break can cause blood infection, and it causes your skin to get nasty looking, blistery. Your white blood cell count will go up. You can have weeping because of it. It can just be pretty gross. Fever. Alright, and there's the references, and there's that. So, I hope this was helpful. I apologize that my voice is about to go. And if you have any questions, please use the discussion board. That's what it's there for. And also, don't forget to vote on Tuesday, which I'm going to put in an announcement too, but I just wanted to say it because I forgot to say it in class. Alright, peace out.